Hello everyone, welcome to our channel. Today we are going to discuss about the dermatology rapid revision as a part of our mission to 100 plus. 1 month, 1 plan, 1 goal, Fmge 2026. So let's start the dermatology topic. As per the dermatology topic, anatomy is also very important. Okay, we have the three most layers. One is the epidermis and another one is the dermis, and last layer will be the hypodermis. So outermost layer will be the epidermis. It will be having the vascular. Okay, no vascular supply will be presented, and these avascular will be contains the what type of the epithelium, guys? Stratified squamous epithelium. It contains stratified squamous epithelium, whereas dermis is mostly contains the connective tissue and circular, and vascular circulation will be present here. And hypodermis, which will be mostly fat and the adipose tissue, and large vessels will be present, like it will be like a act as a cushion to the all uppermost layers. So then after that epidermis is subdivided into the many other layers. How can you remember this layers? Remember the mnemonic: come, let's get sunburn. Okay, come, let's get sunburn. Okay, stratum corneum, stratum lucidium, stratum granulosum, and stratum spinosum, and stratum basale. Okay, these are the layers that you have to remember. And lucidium is mostly, these lucidium will be present in the palms and soles only. And basale is mostly mitotically active. Mitotically active for the stem cells. Okay, at least these will be important for you to layers by layers. And this microscopic picture, you can understand this looks like, what is the feature this we are seeing here? Tennis, right? Tennis racket shape. This tennis racket shape is seen in the macrophage of skin. What is that cell known for, guys? Langerhans cells. Okay, Langerhans cells. This is very important, and the origin also asked sometimes. It is derived from the mesoderm. And what are the markers that we use commonly? CD1A and S100. These are the two that we are going to use for the Langerhans cells. And where this Langerhans cells is presented, these are present in the stratum spinosum. It is present in the stratum spinosum. Next, some other cells also present here. Here you can see the Merkel cells. Merkel cells are usually for the mechanoreceptors. Okay, they act as a mechanoreceptors for the touch, and they derived from the ectoderm. Next, we also have the keratinocytes. These are almost 90% of our skin will be keratinocytes only. And next also we have the melanocytes. Here you can see these are the melanocytes. These usually present in the basal region, which will be producing the melanin, right? Melanin for our skin tone. And melanosomes are derived, these are derived from the neural crest. These are derived from the neural crest. These are the important points that you have to take note. Next one, Langer cells, Langer lines and the Blaschko lines. What are the difference between these two? Langer lines are usually associated with the skin tension. Okay, here in this picture you can see this will be associated with the skin tension. Whereas Blaschko lines, it will be representing the epidermal cell migration. Epidermal cell migration, it will be associated. Next, what is the difference between these two? Importance. The importance of the Langerhans cells will be, it is useful for the surgical incisions. Okay, because these are associated with the collagen fibers. Okay, it will be skin tension, usually importance for the surgical incision, and everywhere where these lines are present, these are going to find with the collagen fibers, so that the scar formation will be decreased and healing will be very fast. And Blaschko lines, it is for the represent of the epidermal cell migration. And what do? They does not follow the any type of dermatomes or collagen. Neither they are going to have the vascular and lymphatics. Okay, they always see these kind of the shapes will be seen with this. Okay, It is not a horizontally and continuous. It is like a S shape or V shape. These kind of the shapes will be seen. And it is associated with the pathology like diseases such as pigmentosa diseases like incontinentia pigmenti. These are associated with the Blasco lines. Next, we are going to moving to the skin lesions types. So these are the primary skin lesions where you are going to see the nodule and cyst and bullae, macule, plaque, wheal and vesicle and pistil. What are the difference between this? So plaque will be more than 1 centimeter. Wheal will be also more than 1 centimeter. And vesicle, you will be having the fluid filled and it is less than 1 centimeter. And bullae is also more than 1 centimeter, which will be same like the vesicle, but more than 1 centimeter. Pistil will be containing the pus less than 1 centimeter. Macule is different with the patch. Macule is less than 1 centimeters. Whereas opposite to this, there will be a patch. Patch will be more than 1 centimeter. Nodule will be consisting of the hard substances, same as the cyst also, but the cyst will be sometimes associated with the fluid or it will be also again cystic hard substances only. Next, what is the difference between the cyst and the nodule? Nodule is movable whereas the cyst is immovable. Next one. These are the secondary lesions. Okay, these are the secondary lesions. Secondary lesions will be ulcers, fissures. There will be a break between the skin and scaling due to the more and more itching. And if that itching is continuously present, these going to form these kind of lichenification and erosions and atrophy. These all are going to be the secondary lesions. Next, moving on to the infectious disorders. In the infectious disorders, you have to take note of these four very importantly. So the first two here you can see this is the non-bullous impetigo. And this is bullous impetigo. The most common cause for the non-bullous impetigo will be the Staph aureus. And the most common for the bullous impetigo is also Staph aureus only. Okay, so how they are going to present? The lesion will be presented with these kind of honey crest cells. Okay, these kind of honey crest will be presented over the vesicles and pistils. And when they rupture, they are going to form this kind of crust. And other symptoms, systemic symptoms will be presented also. And what is the treatment that we can give for this patient? Topical antibiotics such as mupirocin can be given for this. And next, bullous impetigo, mostly extensively the bullae will be presented. And this bullae is going to be the flaccid bullae. And when they rupture, they form the crust, but not honeycomb type. Okay, this crust is not honeycomb. And usually they are going to involve the oral plus anal region and also trunk. Okay, and very painful. This is the bullous impetigo. And these patients need the oral antibiotics. Okay, and non-bullous impetigo is still Staph aureus only. But if it is associated with the strep, the complication for this will be going to the post-streptococcal glomerulonephritis. This can cause the post-streptococcal glomerulonephritis. Next, from these two pictures, you have to understand this is the erysipelas and this is the cellulitis. In the erysipelas, it is going to involve only the superficial layers such as dermis and the epidermis. Okay, mostly upper dermis only involved. Whereas cellulitis, it is going to deeper to the dermis and also subcutaneous fat. It is also going to involve the subcutaneous fat. So erysipelas is most commonly, it is going to involve the group A streptococcus. Okay, group A streptococcus is the most common cause. Whereas here it is going to be the most commonly streptopyogenes and also group A streptococcus and Staph aureus. All these organisms will be presented for the cellulitis. And cellulitis is very extensive condition. Okay, how can be it is ill demarcated. When you are going to find out what is this for the differentiation, it is does not going to have the demarcation. Okay, ill demarcations and poor margins. Red erythema will be presented, and warm legs mostly seen with the during the when we touch, the lesion will be tender and warm. Okay, this is how cellulitis. Whereas erysipelas, there will be well demarcated lines. Okay, the borders will be well demarcated and raised. You can see the swelling opposite here. It is going to be the raised, and again here also the erythema will be presented. And less likely to be these patients will be having the tenderness. Okay, like here you can see this clearly looks like a orange peel appearances, and these can be complicated and it can even lead to the necrotizing fasciitis, and it is rare likely leading to the necrotizing fasciitis, and most commonly it involves the face and it will be involving the lower limbs and the limbs. And next, this is here you can see this is the staphylococcal skin scalded syndrome. Okay, staphylococcal scalded skin syndrome, and this is going to be caused by the staph aureus, most commonly with the toxins. Okay, exfoliative toxins. It will release the exfoliative toxins into the skin A and B. Okay, and it is going to target the desmoglein 1. Within the skin, it is going to target the desmoglein skin and cause the subcorneal splint. In the dermal layer, it is going to cause the subcorneal splint. That's why when you see this patient, it is going to see the severe erythema, and the lesions will be going to no, the lesions is going to be slow off. Okay, here you can see these kind of peeling will be seen in the patient, and it does not going to involve the mucosa, and the Nichols sign is positive here. Nichols sign is positive in this patient, and no scarring will be seen. After the healing also, there will be no scarring, most commonly seen in the neonates. Next, coming to the folliculitis, furuncle and carbuncle. These three are going to be caused by the Staphylococcus aureus only. And how these are going to be the mostly which involves the superficially, that is going to be your folliculitis. Okay, if between the follicles where this follicles is going to present it, the lesions are going to be erupted. Next, furuncle will be filled with the pus, and it is going to involve the dermal region. Whereas carbuncle, it is going to involve the deeper dermis. Along with that, it is also going to cause the multiple pusses. Okay, whereas furuncle is only one pus, carbuncle is formed by the multiple pus. Okay, this furuncle and the carbuncle is the incision and drainage, whereas the folliculitis can be treated with the oral or the topical antibiotics. Next picture, here you can see this is the erythrasma, right? This is the misnomer sometimes included in your tinea infections. And when you see this picture on the wood lamp, what is the color that you are going to see? Coral red appearance. Okay, coral red appearance you are going to see. What is the causative agent for this, guys? Corynebacterium. Okay, Corynebacterium minnesota. This is the most common cause for the erythrasma. Next pictures, here you can see this is the cold sore and the herpes, right? Cold sore, this is also one of the questions that is asked in the examination. It is caused by the HSV1, and this is known as a oral or the herpes labialis. Okay, oral or the herpes labias, most commonly seen with the STD, saliva, or direct contact to the lesions. And also it is the latency of this HSV1 is seen in the trigeminal nuclei, trigeminal ganglia. And genital herpes, this is caused by the HSV2, and it is the genital herpes, most commonly STD only, and seen only in the genital regions, those who contact with the sexual or the perinatal region. Very painful lesions, vesicles that is going to be presented, and the ganglia that is involved by this one is the sacral ganglia. Okay, sacral ganglia. Both are going to be very painful conditions for the patient. Next, another picture. This is the herpes zoster, right? Herpes zoster. This is going to be due to the patient, those who are having the latency period, the varicella zoster virus, this is going to cause this one when the latency period. And during this latency period, where that is going to stay, during this, it is going to stay in the dorsal root ganglia. When it is triggered, it is going to cause this dermatomal. Unilateral, okay, dermatomal, and very painful condition. Most common dermatome that is involved is the thoracic region. Okay, thoracic that is going to be involved here. And what are the other forms that is presented with the herpes zoster? Ramsay-Hunt syndrome, and also zoster ophthalmicus, where you are going to see the positive of the Hutchinson sign. Hutchinson sign. What is mean by the Hutchinson, guys? This is going to involve the nasociliary nerve near the nasal region. Next, another picture here you can see, this is the molluscum, right? Molluscum contagiosum, where you are going to see these kind of the lesions, the small pearly dome shaped or the umbilical shaped lesions that you are going to see. This is caused by the pox virus. And molluscum contagiosum is also most commonly associated with the STD. And if it is involves the children, it is going to be the direct contact. And if it is involves the genital regions and the adults, it is a sexually transmitted disease. Okay. And next, coming to the histology. This histology pictures here you can see, this is known as a Henderson and Peterson bodies. Henderson and the Peterson bodies. This is the common feature or the nuclei that you are going to see in this picture of the molluscum contagiosum. And next, coming to the HPV warts. Okay, and these HPV warts are commonly associated with the hands, foot, and rough surfaces. Okay, these are the common one. The serotypes are the HPV1, HPV2, and the HPV3 and 4. And what are the other warts? There will be the genital warts, and these genital warts is going to involve the 6 and level due to the sexually transmitted diseases. And when the histology on the this is also anogenital warts 6 and level. On the histology, you are going to see the coilocytes. Okay, on the histology, you are going to see the coilocytes. And what is the treatment, guys? The treatment for this is usually cryotherapy. Okay, usually cryotherapy, that is safe for the pregnancy patient also. Safe for pregnancy patients also. Other than this, we can also give the imiquimod or the other drugs, but that is not given in the patients of the pregnancy. As the PYQ, the cryotherapy is given for the pregnancy patients. Next, moving on to the fungal infections, the classical pictures, pityriasis versicolor, right? Hypopigmentation or the hyperpigmentation will be seen. What is the organism that is involved here? That is Malassezia globosa or Malassezia furfur. This is the pityriasis versicolor, seen in the usually young adults, those who are having the humid climates, oily skin, that will be seen. And these lesions are well demarcated, guys. Here you can see, you can differentiate between the hypo or the hyperpigmentation from the skin and the lesions, right? Mostly involves the trunk. On the histology, you are going to see this meatball appearance and the noodle appearance. So that's why it is known as a spaghetti meatball appearance. Spaghetti meatball appearance. And on the wood lamp, you are going to see the yellow-green fluorescence. Yellow and green fluorescence that you are going to see. Because this Malassezia globosa is going to cause the, with the help of the azelaic acid. The help of the azelaic acid, they are going to cause this pigmentation like syndrome. Okay. And next one. Moving on to these three important epidermophytons. In the epidermophytons, the trichophyton is going to cause the skin, so remember, like skin, hair, and nails. These three are involved here. Next, microsporum. This is going to involve the skin and hair. And epidermophyton is going to involve the skin and nails. Okay, skin is common among all. And tri means all three is going to involve. Microsporum, only micro hair will be involved. Epidermophyton, skin and the nails will be involved here. Next, coming to the tinea, different types of the tenias. So here you can see the picture. The tinea is going to be tinea capitis, which will be involving the our head and hair. And next one is the tinea corporis. Okay, only this will be involving the body. Next, tinea pedis, the foot. The foot is going to be involved here. Tinea barbae, only the beard region. Tinea barbae. Tinea manum is going to involve the hands. And tinea unguium is going to involve the nails. Okay, whereas other tinea cruris, okay, this is known as a jack itch. It is going to involve the inguinal or our genital region. This is for the patients of the tinea cruris. And other one also tinea incognita. Tinea incognita. These patients are going to have the tinea like lesions only, like ringworm like lesions will be presented. But at the same time, these patients will be having the history of steroids. So when they use the history of the steroids, the lesions will be decreased. But inside that, it's still there will be the infection is present on the skin. Okay, due to the steroids, immunosuppression caused the lesions appearance and no central scaling is seen in this patient. But it is due to incognita. It is not seen due to the steroid use, but the infection is still present. Next, coming to the another tinea types. So we have the non-inflammatory type and the inflammatory type. Okay, non-inflammatory. Non-inflammatory types are two types. One is the black dot and other one is the gray patch. Okay, black dot and the gray patch. Black dot is going to involve the patchy. Okay, patchy alopecia with broken hair. Whereas gray patch, it is going to be seen with the gray scaly lesions. Okay, gray scaly lesions again with alopecia. Okay, that is seen. Next, coming to the inflammatory type. Inflammatory type, this is very going to be the severe condition. Example, you have the favors. Okay, these favors here, you can see this is the favors, which is known as a scutula. Which is known as a scutula. Next, carrion. In the carrion, what happens? These patients will be having the lymph node involvement. Lymph nodes are involved along with that boggy swelling. Okay, boggy swelling is present in this patient. So this is for the patients. So here again, here you can see this is the carrion type, like abscess will be presented in this patient. This is the black dots. Okay, this will be alopecia, like patchy alopecia is seen here, and broken hair in between. And this is the scaly type. This is known as a gray patch. And this is the scutula, our favus. And there is a question, what is the drug of the choice for this patient? The drug of the choice for this patient is the griseofulvin. Okay, oral griseofulvin is given for this patient as a drug of the choice. Next, coming to the another picture here. What is this condition known as, guys? Madura foot. Okay, Madura foot, and the other name, it is known as a eumycetoma. Eumycetoma. Why this is given as a Madura? Mostly the first case is seen in the Madura region of the Tamil Nadu. And that's why it is name also known, the organism that is going to involve this one is known as a Madurella mycetomatis. And very extensive. Sometimes we are going to do the incision and drainage. And even if it is extensive, that we have to cut the and amputate this leg. And other one also present, other organism, that is acetomycetoma. Acetomycetoma. This is going to caused by the bacterial type, acetomyces or the nocardia. This is what. And Next coming to the here. Next coming to the another two types of the infections. What is this condition known as, guys? Sporotrichosis, right? Also known as your Rose Gardner disease. And the classical picture of this one is that it is going to involve the lymphatics. Okay, the lesions are going to be the lymphatics. The linear pattern will be seen. It is like a nodule and the ulcer will be formed with that. And on the histology, you are going to see the asteroid body. Next coming to the chromoblastomycosis. Okay, and this one is like a verrucous black and patchy, verrucous black patchy, and it is going to look like a cauliflower like lesions. And chromoblastomycosis is the patient will be former with trauma. History will be former with trauma. Okay, and on the histology you are going to see this one. These copper penny bodies you are going to see. Okay, this is how we are going to differentiate between the all these important infections of the fungal. Next, moving on to the parasitic, and the most important one parasitic is the scabies, right? Here you can see. Scabies is caused by the this common infection. What is the organism name, guys? Sarcoptes scabiei. This is the common organism that is going to see. And what happens when this Sarcoptes scabiei, it is going to caused by the female only. Okay, these females will do the burrows. Okay, burrows into our stratum corneum during the nocturnal period. So these nocturnal period, when they are doing the burrows, we are going to have the itching. Okay, especially in the hands, genitals. And it is going to involve the blue line of Hebrae. Like circular pattern in a human body, if you take, so it is going to involve this particular region, like flexures and the extensors, and also genital regions, umbilical region, it is going to involve. This is known as a blue line of Hebrae. And if it is extended, the crusted type of the scabies will be seen, especially in the immunocompromised HIV patient, known as Norwegian scabies. Okay, Norwegian scabies. And what is the treatment that we are going to see? And also remember one more thing, the family history will be positive in this patient. Okay, one among the other will be also having this type of condition. Next, coming to the treatment plan. Treatment, usually we are going to start, then the most commonly used or the drug of the choice is the permethrin. And how we are going to give? Twice a week. Okay, twice a week, that is enough. At least 2 times of the dosage is important for this patient. Next, it is given for the all the patients, pregnancy patient and also less than children, 2 years also we can give. Next, linden 1% of the lotion, but it is contraindicated in the pregnant patients with the pregnant and the seizures, because this linden is going to cross the blood-brain barrier. That's why it is not recommended for the neuro patients, pregnancy patients and the infants. Next, benzoyl benzoate 25% of the ointment. Again, this is also not given for the pregnant women and the infants. Next, another one, crotiometin. This is can be given for the nodules, especially in the children, that we are going to give the crotiometin. And this is also safe for the patients with the pregnancy also. Ivermectin is like a placebo effect. When there is a superficial infection also, we are going to start. 200 micrograms per kg is given for the first day and also again on the 7th and the 14th day. This is for the ivermectin. And again, this is not given in the patients with the pregnancy or the breastfeeding women. Okay, remember these points for the treatment. Next, moving on to the autoimmune bullous disorders. So first, pemphigus vulgaris. Vulgaris, its name that is most commonly seen. Okay, what is the pathogenesis between the pemphigus vulgaris? It is going to cause the antibodies effect against the desmoglein 1. Desmoglein 1 plus also desmoglein 3. Whereas pemphigus foliaceus, it is the antibodies involves the only desmoglein 1. Desmoglein 1. Pemphigus vulgaris is going to cause the flaccid bullae, which will be rupture easily. And it is also going to involve the mucosa. So oral lesions will be also present in this patient. Next, pemphigus foliaceus, it does not going to involve the no oral lesions or no mucosa involved, but it is going to cause the superficial scaling and bullae. Next, on the histology, what you are going to see here, on the histology, there will be a suprabasal layer. Okay, acantholysis seen in the suprabasal layer. Here you can see, this is the suprabasal layer split that you are going to see. That is seen in the patients of the pemphigus vulgaris. Pemphigus foliaceus, again here, you are going to see, this is the acantholysis in the subcorneal layer. What happens here? The suprabasal is involved above the basal layer. Subcorneal layer beneath the stratum corneum layer. Next, what about the Nicolsi sign positive? So the Nicolsi sign is going to positive here, and also Nicolsi sign is positive here. Both the conditions also going to be caused. Next, coming to the immunofluorescence of the pemphigus vulgaris, it is going to seen as a chicken wire appearance. Chicken wire appearance with the help IgG immunoglobulins, there will be a C pattern. Chicken wire, or we can also say fish net appearance. Okay, fish net appearance is also seen here. Same pattern also seen in the here also. Next, the treatment. Here the treatment, we can going to start this patient on the rituximab. Okay, and here the steroids can be given for this patient. This is the main difference between the pemphigus vulgaris and the pemphigus foliaceus. Next, here it is a bullous pemphigoid. This is seen in the patients of the elderly patients, and how their lesions will be presented. It is the tense bullae, and they does not rupture easily. They are not going to rupture as easily. Okay, and what are the antibodies that is going to affected here? The antibodies is going to target the BP 180 and BP 230. These are going to be acted. Where these are presented? In the hemidesmosomes place. Okay, hemidesmosomes, where their antibodies are going to be present here. And another feature that you can remember, the Nicolsi sign is negative here. Nicolsi sign is negative in this patient. And on the immunofluorescence, this is the basement membrane. This is the basement membrane, right? Where you are going to see this pattern. Okay, IgG plus C3 is going to be seen in the immunofluorescence of this patient. And treatment will be again, he is given the steroids only. Next, dermatitis herpetiformis. This is dermatitis herpetiformis, most commonly associated with the celiac disease patient. Okay, celiac disease patient. How it is going to be affected? IgA, right? IgA is going to be affected. The herpes like is like a misnomer, but the patient will be having the intense itching. Next condition, psoriasis. Psoriasis, let's see types. This is known as a plaque psoriasis, commonly involves the extensors. Most common, this one. Okay. Next one, guttate psoriasis. And this is going to caused by the infection. Infection type, systemic signs like fever, that is also going to seen in the patient. Next, inverse psoriasis. Inverse psoriasis, commonly in the skin folds. Commonly seen in the skin folds. Next, pustular psoriasis. Pustular psoriasis associated with the increase in the WBC cells. Next, erythrodermic. Erythrodermic lesions. Extensive widespread erythema inflammation will be seen in this patient, and it can be life-threatening also. Next, what are the nail changes that you are going to see? Pitting, this kind of the pitting will be seen, and also deformation of this patient, thickening. Here you can see the thickening of the nails, onycholysis, the breakdown of the and the complete destruction of the nail plate, and also discoloration. These all features will be seen in this patient, and also oil drop sign is also seen in the patients of the psoriasis. Monroe's abscess. Monroe's abscess is also seen in the patients of the psoriasis. Another important sign that you have to remember, Auspitz sign. What is the Auspitz sign, guys? When you break, when you do the lesions, when the trauma is scratched or cutted, then you are going to see the bleeding, pinpoint bleeding seen, that is known for the positive of the Auspitz sign. In the treatment of the psoriasis, the first line of the drug of the choice will be the vitamin D analogs, okay? That is calcipotriol. This is the initially we are going to start. But if the patient is having the more kind of the moderate or the mild disease is transmitted, then we can go for the steroids, okay? Along with the steroids, we can also start the systemic agents like methotrexate. Methotrexate like drugs can be also are added, and the cyclosporine. And also if it is more severe refractory diseases, then we can add the monoclonal antibodies, so such as TNF. Okay, TNF inhibitors also we can add. So what are those? One of the examples that you can remember is the etanercept and infliximab. These two can be added. And also nowadays we are going to also add the IL-12 inhibitor, that is known as the ustekinumab. This is also adding it. Next, phototherapy. Phototherapy can be also added as an adjunctive therapy. This is for the moderate disease. We are going to use the UVB and OVA. This is going to be added for the patients. All right. Next, moving on to the lichen planus. Lichen planus will be easily remembered by the 6 P's. What are those? 1 P is itself lichen planus. And next one is the papule, and also plaques, pruritic, polygonal, and purple. So these are the lichen planus. Simply, it is a chronic inflammatory immune associated condition. It will involve the skin, it will involve the mucosa, and also it is going to involve the nails. Okay, these are the 3 features that is presented with the lichen planus. And on the mucosal involvement, here you can see the classically this lesion will be seen in the whitey pearly layer is seen in the inside the mucosa. And here on the skin, you are going to see the feature of the Wickham striae. Okay, Wickham striae, the fine whitey lacy lines that you are going to see between the lesions. That is for the Wickham striae. And nail changes. Nail changes are the pterygium formation. Okay, pterygium formation is seen on the nails. Next, moving on to the pityriasis rosea. This is caused by the usually associated with the infected like HHV 6 or 7 commonly associated with this pityriasis rosacea, and you are going to see the herald patch. This is known as a herald patch. What does mean by the herald patch? This is the mother patch. Okay, herald or the mother patch, the first patch to appear on the skin. So after following that, these many lesions that you are going to see. And another one from this picture that you have to understand, this sign is known as a Christmas tree pattern. Christmas tree pattern, right? Like this. This is known as a Christmas tree pattern. Smaller scaly plaques that will be seen on the tension lines of the both the truncal region. And this is a self-resolving pityriasis rosacea. The scaling will be presented and self-limited condition due to infection. Next, moving on to the pigmentary disorders. This is known for the vitiligo. This is albinism. This is the albinism, and this is the vitiligo. Difference between the albinism and the vitiligo. This is the genetic condition, and this is the autoimmune condition. Okay, completely the tyrosinase is deficient here. The vitiligo is going to attack its antibodies in the, usually for the patient, the melanocytes are most commonly affected here. Next, this is the baldism, autosomal dominant disorder, only involves the most commonly like very remote regions. For example, this temple region, like T-shaped this region, and the upper hair is only going to be involved in this patient. Next, this is melasma seen in the reproductive plus OCP use women, commonly seen in the hypermelanosis sun exposed regions. Okay, more melanocyte activity, more commonly in the women, those who are using the OCP salt. Next, this is pityriasis alba seen in the children. Again, pityriasis means it is scaling, common in the children, usually associated with the inflammation and also due to nutrition deficiency. Nutrition deficiency self-limited only. Next, three differences that you have to know. One is the Becker nevus, nevus of Otto, and nevus of Ito. What does this mean by? Okay. So Becker nevus is most commonly is due to patients those who are associated. Becker nevus is seen in the patients of the adults. Okay, puberty, post puberty, you are going to see this Becker nevus. Usually involves the upper trunk, and always it is going to be the unilateral. Becker nevus is seen in the adolescents, involves the unilateral shoulder region, okay, and hyperpigmented hair. Hyperpigmented hair that will be present in the Becker nevus, most commonly seen in the male patient. Next, nevus of Otto. Nevus of Otto. Here you can see these nevus of Otto will be seen in the children also, early childhood or by birth also it is seen. Again, this is also unilateral and involves the cornea also. Cornea is also involved, and no hair. No hair is present in this patient. Next, again, coming to the nevus of Ito. Ito is going to be followed the supraclavicular or the scapular region. Again, no hair, no cornea involved. Okay, this is the main difference between the Otto, Ito, and the Becker nevus. Next, moving on to the acne, the grades that you have to remember. The first grade will be the involves the black and white, or we can say open or close. Comedones will be seen in this patient. Right? Next, grade 2, where you are going to see the papules plus pustules. And grade 3 is extensive, more severe. The grade 3 is going to involve the pustules and pus or the abscesses. Next, this is almost extensive, nodulocystic. Okay. Next, what is the most commonly the treatment that we have to use in this patient? The grade 1 treatment will be topicals only. Topicals such as retinoids, that is commonly used. Next, grade 2. In this grade 2 also again topical retinoids and also topical antibiotics. Okay, topical antibiotics also used here. Next, grade 3, you are going to give the topicals plus due to abscess and the pustules is presented, then you have to give the antibiotics orally. Clindamycin is commonly used. Next, grade 4 is going to be the extensive, right? Here you are going to give the oral retinoids. Example, oral isotretinoin is given for this patient. Okay, this is for the grade 4. Next, coming to this picture, this is rosacea. This is rosacea and the usually seen in the females reproductive age. And in the if it is in the involves in the males, it is going to cause the rhinopima, potato nose. Right, this is the rhinopima also seen in the males. Next, coming to the hair and nail disorders. So the first one, this is known as the alopecia areata. Alopecia areata. Right, this kind of patches will be seen in the patient, autoimmune condition. Whereas on the when you are going to see this under the microscope, you are going to see this one, this sign, exclamation mark. Okay, exclamation mark will be seen due to the broken hair of the margins. Like this is associated with the autoimmune condition. Okay, autoimmune condition. Next, again, steroids is the treatment and it is reversible condition also. Next, moving on to the androgenic hair loss. What is happening here in the androgenic hair loss? When there is a dehydrotestosterone is going to cause the miniature of the, this is going to cause the damage to the hair follicles. Damage to the hair follicles. What happens? Usually in the males, it is going to involve this vertex. Okay, this vertex is commonly affected in the males. Whereas in the females, it is going to cause the frontal hairline or the mid hairline, the crown, over crown. This pattern will be seen in the females. Okay. Next, what is the treatment for them? The treatment for these patients, usually we are going to use the minoxidil. Okay, minoxidil or the finasteride because it is androsterone, right? This is we are going to use, and spironolactone can be also given for the female patients. Okay, next, other types that you have to know, anagen and the telogen effluvium. Okay, see, anagen, effluvium and telogen effluvium. What is the difference between these two? Anagen effluvium is going to be associated with the anagen phase, right? Most commonly seen in the post-chemotherapy. Telogen is associated with the follicles that is falling in the resting phase or the telogen phase. And this is associated with the infection or stress. Okay, post-stress or the post-infection, telogen effluvium. With the history of corona or some other, then it is telogen effluvium. Chemotherapy and the patient is having the radiation toxins, then it is anagen effluvium. Both are reversible conditions only. Next, this condition is known as a trichotillomania. Trichotillomania. And this is seen with the psychiatric condition when they pull, okay, this like broken hair and blood. This is commonly seen with irregular patches and the broken hair, and also the blood like this one will be seen in the patients of the trichotillomania. One thing that you have to remember. Next, coming to the STDs and the genital dermatomes that is involved. Next, chancroid. The most commonly this is due to Haemophilus ducreyi, and syphilis. You all know that this is due to Drepanomus species, and the lymphogranuloma venerum. This is due to chlamydia, the species of L1 to L3, and donovenosis is due to Klebsiella species. Okay. Next, coming to the features. What is the features? So chancroid is painful ulcer. Along with that, painful lymphadenopathy seen with the chancroid. Okay, this base is very painful in the patients of the chancroid. Next, here it is painless ulcer or the chancroid. Okay, and also painless lymphadenopathy. Okay, rubbery lymphadenopathy that is seen in the patients, both bilateral, and this is usually unilateral in the chancroid. Next, lymphogranuloma venerum. There will be painful buboes. Okay, and also there will be a groove sign. This is known as a groove sign positive. Painful buboes and the groove sign is positive for the lymphogranuloma venerum. Next, donovenosis. It looks like painful, but it is painless, beefy red appearance with no lymphadenopathy. Only pseudobuboes is seen. Pseudobuboes is seen in this patient. Next, what is the other features that you have to remember? On the culture, you are going to see the school of fish or the railroad appearances. And the treatment will be azithromycin. Next, coming to the syphilis. Syphilis, you are going to see the dark field microscopy, right? Dark field microscopy we are going to use, and the treatment will be penicillin. Next, coming to the lymphovena granuloma, we are going to use the nucleic acid amplification test for the chlamydia, and the treatment will be doxycycline, and here the treatment will be azithromycin. And on the diagnostic, you are going to see the safety pin appearances. You are going to see here. Next, another picture that I forgot to mention here, nail disorders also. So nail disorders, here you can see this is the spoon nails, right? Spoon nails are also known as a polionychia, right? Mostly seen in the iron deficiency anemia. Next, this is the pitting of the nails. We discussed now, seen in the psoriasis patients. Next, this is the view lines. Okay, this is the view lines. Usually associated with the injury, most commonly trauma, or also coronary occlusion, coronary diseases, and decreased calcium. And another poisons like chemotherapy or the malnutrition. Next, this is clubbing, most commonly seen in the pulmonary lung diseases like COPD, tuberculosis, emphysema, bronchiectasis, cystic fibrosis, and also some of the heart diseases. Okay, this is seen with the heart and lung diseases. Congenital lung disease also we are going to see. Next, this is the thickening, usually seen in the autoimmune conditions and also fungal conditions. Next, this is the leukonychia, usually again malnutrition. Terminals are seen in the liver diseases. Lindsay diseases are seen in the CKD or the end-stage renal disease patients. Next, moving on to the leprosy and the tuberculosis. This condition is known as the lupus vulgaris. Okay, lupus vulgaris. The misnomer, it is not a lupus condition. How we are going to see this patient? Usually, this is the most common TB presentation on the skin. And how they are going to present it? The verrucous plaques. Okay, this is how the verrucous plaques will be seen on the patient. And on the microscopy, it is going to present it as a apple jelly nodule. Okay, granulomas is also seen. Caseated granulomas are seen in this patient. Next, coming to the second one, this is known as a crofculoderma, most commonly seen in the children age or the pediatric patient. Okay, and it will be involves the lymph node. Along with that, there will be a presentation of the abscess. Okay, usually cervical lymph nodes are commonly involved in this patient, and this is painless. Okay, and it is associated with the painless but the discharge is present at this point. Okay, tuberculosis, verrucosa cutis. Okay, this is the warty appearance. Okay, warty and verrucous appearance. Very slow progression that will be seen in this patient. Next, moving on to the deadly jobbling classification seen in the Hansen or the leprosy patient. Right? Next, coming to the leprosy is a chronic infective mycobacterial granulomatous disease. Right? We have the five types of the classification for the Ridley Joblin classification. Let's see the differentiation. First, tuberculoid type. These tuberculoid types are usually contains only 1 to 3 skin patches, and these patches is also going to be the annular, well defined and central clearing is seen in this patient. Okay, also called as a saucer shape, that is seen in the tuberculoid type. Next, coming to the borderline tuberculoid, this is the most commonly seen in the India. 3 to 10 lesions, not well defined. Satellite lesions also present here. Next, moving on to the borderline type, and this is also mostly contains the more than 10 lesions, map like or the geography lesions are appearance, and punched sign is seen here. A punched sign is seen here. Next, borderline lepromatous BL type. This is nerve is also going to be involved here. Okay, skin lesions will be completely thickening. Nerve thickening is also seen. And inverse saucer type. Next, last one, lepromatous leprosy. This will be involves the skin plus nerve, and also other organs will be involved. Leonine phases are seen in this stage. And glow stalk peripheral neuropathy is also seen in the lepromatous leprosy. This is the one of the type that you have to remember. Next, some of the important points. The most common nerve that is involved is the ulnar nerve. What is the first most commonly involved sensation that is lost? Temperature. Most common cranial nerve that is involved is the cranial nerve 5, trigeminal nerve. Okay, and on the peripheral nerves thickening. Peripheral nerve thickening, it is going to involve the greater auricular nerve. Greater auricular nerve that is going to be involved in this patient. Next, coming to the histopathology, you are going to see the subepidermal free zones that will be seen. Next, another points that you have to remember here, the lepra reactions are the paucibacillary and the multibacillary. What is the paucibacillary and the multibacillary? Paucibacillary is only going to be the 1 to 5 lesions, no nerve. Here, more than 5 lesions, nerve is also going to be involved. So the treatment will be 6 months. Here the treatment will be 12 months. All right. Next, moving on to the reactions. Type 1 versus the type 2 lepra reactions. Both are associated with the treatment. So continue the treatment. Here also treatment should be continued regardless. Next, what is the presentation? It will be associated with the neuralgia. So the painful lesions will be seen. Here it is associated with the lesions, extensive, painless. What is the hypersensitivity reaction? Hypersensitivity reaction 4, hypersensitivity reaction 3. Rule of 5. Okay, this is what we are going to follow for this patients of the leprosy. Next, moving on to the STD kits, very important one that you have to remember. So the gray kit will be urethral discharge, portal filling, or the cervical discharge. What is the drug that we are going to give? Azithromycin and the cefixime. And partners, yes, all the partners will be given treatment. Next, grade 2 vaginal discharge, like most commonly the candidiasis or the trichomonas that is going to be involved. Antibiotics or the total topical fluconazole can be given for this patient. Only when the partner is also symptomatic, then we are going to give. Third one, white color kit, genito ulcer, which is non-herpetic. So benzyne penicillin or the azithromycin can be given for the patient. And treatments also treated. Next, blue one is for the non-herpetic. Again, this is given with the doxycycline and the azithromycin. Again, partners is also treated. Next, red kit for the herpetic type, acyclovir antiviral is given. No partner is treated for this patient. Next, sixth one, lower abdominal pain, cefixime, metronidazole, doxycycline, and partners is also treated here. Next, black one, inguinal bubo, where you are going to give the azithromycin and the doxycycline. Again, all the partners is also going to be treated here. So this is the overall most important topics that we have discussed in today's lecture of the dermatology. Those who are new to this channel, do subscribe and share with your friends, and do revise and read this PDF and also practice the MCQs.